Welcome, everyone. My name is Joe Merighi, and I'm the chair of the Human Behavior Department in the School of Social Work. And together with my colleague, Dr. Deanne Bonner, who is the chair of the Curriculum Committee, we are delighted to have Dr. Janice Funk speak today to speak about neuroscience. And this is part of an effort to inform the BUSSW community about important issues and emerging issues. So I'd like to say that Dr. Janice Funk is a clinical neuropsychologist with over 25 years' experience in the assessment of brain behavior relationships. She graduated from the University of Texas at Austin and received her postdoctoral training in neuropsychology at the University of Houston and Baylor College of Medicine. Dr. Funk was awarded a fellowship in geriatrics at the University of Texas Health Science Center, and she is associate editor of the journal Cognition and Aging. Dr. Funk is the director of the Whittier Memory Clinic in Haverhill, Massachusetts, and the Whittier Memory Clinic provides assessment and treatment to members of the community with dementing illnesses. The title of our colloquium today is Dr. Funk's Greatest Hits, Myths and Realities in Neuroscience. There will be 3 very brief Q&A segments after each of the 3 sections you see above. So I ask that if you have a question, please wait for us to provide you with a microphone so that we can capture your question appropriately. And with that, please welcome Dr. Janice Funk.
Thank you very much, and thank you for inviting me here today. I'm going to present today 3 very brief sections of longer presentations, which I have done for the BU School of Social Work, and these are the titles here. One of them is on depression, one on the neurobiology of love, and the third on Alzheimer's disease treating dementia, which is actually my day job. That's what I do. And I know that part of the goal here today is also to help the faculty think about adding interest into their own lectures. And so for later on today, if you would like to also ask me about slide creation and also little things like, for example, I'm going to actually give these today in a different order. And how to do that, I can actually all of the slides are designed by me, and I control all of the content and all the movement and everything on the slide. So not only can you ask me questions about issues in neuroscience, but also if you're interested in how to make presentations look like this. And before I move on to the first presentation, we're going to talk about what I do, which is treating dementia and Alzheimer's disease. I would like to comment very briefly about, because I try and put information on each slide to make it look interesting. And this is an artistic, a pretty, and very useful slide. This happens to be where the antidepressant effexor hits the brain. And in this particular slide here, you can see that this type of scan is the one that goes through the side. This type of scan, when it looks like this, is coming top to bottom. And when you see something that looks like this, it's going through the brain. So this slide also shows people the orientation of the scans that are often on the slides. Now, there won't be a lot of scans today. There'll be few. But each of these presentations, each of the 3, actually runs a full day. So when we do that, we actually get into great detail. Today, I'm just going to be hitting the high points. Now, I'd like to begin with a presentation on treating dementia. And we actually have made a lot of progress, and I actually believe that in my lifetime, Alzheimer's disease is likely to be cured. This is a picture of Dr. Alzheimer. And 104 years ago, he described a case study of a woman who had lost her memory to the point that she barely knew her name. When I was a budding neuroscience student, I realized that studying this disease was going to tell us an enormous amount about the human brain. But interestingly, at that time, and this was over 25 years ago, people said, well, you don't want to go into that full time because you'll never have a job. The disease is too rare. We now know that Alzheimer's disease is now going to become, in the next 20 years, the #1 disease in this country. So if you're unfamiliar with the disorder, I would like today to present kind of the myths and realities of this disease. We're going to start with a very brief introduction.
I remember her getting up in the middle of the night to go to work. You know, I'd say, Mom, what are you doing? It's 1 o'clock in the morning. She would look at me really confused, you know, and then she would pretend that she knew what she was doing, but you could tell that she didn't. Her hands are so warm. Your hands are so warm, Mom. She constantly was hiding things, like you'd find strange things like, you know, keys in the refrigerator. And eventually we all said, we think that Mom's developing Alzheimer's.
We knew she was going to lose her memory, but I don't think we were prepared for what transpired.
I love you. I love you, Fran. I love you, Fran. Daddy, I don't know. People ask me, and so how is your sister? And I think, what am I going to tell you? She's losing her mind.
Alzheimer's disease robs you of who you are.
We are staring into the face of a modern epidemic. In the last 8 years, 500 people worldwide have died of bird flu. 500 people worldwide, bird flu, 8 years. We have 5 million people in this country right now diagnosed with Alzheimer's disease. This is the tsunami that's going to hit this country and, to some extent, the rest of the world. Now, I'd like to begin with the basics. What is dementia? I answer this question in my clinical practice every day to help families understand, because the whole family is my patient. You can't have an individual in your family with Alzheimer's disease and not have it affect the entire family. Dementia is defined as an acquired intellectual impairment in multiple areas of mental activity, including attention, memory, cognition, language, visual, spatial skills, abstraction, judgment, personality, and emotions. And these are actually up here in this order because these are the paragraph headings of a neuropsychological test report. Neuropsychologists are perfectly trained to assess the areas that are affected by the dementias. And in fact, for example, when was the last time you went to a physician's visit where in the 15 minutes these aspects of your functioning were assessed? So we don't want to wait until people have such impairments in these functions that you could see it in a mere 10 minutes. We want to be able to see these things much earlier. Now, I actually, there are a lot of dementias, but I specialize in the senile dementias. Children get dementia. It's felt relatively rare. Children also get Alzheimer's disease. That also is extremely rare. But one of the biggest myths that we have to work against in Alzheimer's disease is that somehow this is caused by aging. It's not, and I'm going to go into a great deal of detail today in explaining to you why Alzheimer's disease is not at all caused by aging. But the senile dementias include Alzheimer's disease, something called Lewy body dementia, vascular dementia, which is having tiny strokes, frontotemporal dementia, also known as Pick's disease, progressive supranuclear palsy, corticobasilar degeneration, and the list goes on as these get a little bit more rare. Now, today I will not have a chance to talk about these other dementias given the time limit, so we're going to focus on Alzheimer's disease. However, the incidence of dementia is growing. Today, 5 million people in this country are diagnosed with dementia. Many more people have dementia that is undiagnosed. By 2020, at least 15 million will have dementia, and it's probably going to be higher than that. This is coming up very fast. The incidence increases rapidly after age 65. After age 85, 30 to 47% of all Americans have evidence of a dementia. And the only way that this is not your personal risk is to not live to be age 85. So clearly, this is an enormous number of people.
Anywhere from 25% of people over 85 to Even as high in one study as 47% of people over 85 have some level of dementia. That's an incredible number of people with disease.
And interestingly, the studies with the highest number, and the 47%, was done here in Boston. It is one of the better studies, and it was actually done at Massachusetts General Hospital by the faculty there, and it was done by going door to door. So it picked up people who might not know to go in to the doctor for assessment. When they do that, they tend to get higher numbers. So this is clearly going to be a major, if not the major, medical issue of the next 20 years. At current rates, there will be a 27% increase in Alzheimer's cases by 2020, a 70% increase by 2030, and a 300% increase by 2050. If left unchecked, it is no exaggeration to say that Alzheimer's disease will destroy the American healthcare system and bankrupt Medicare and Medicaid. This is the true epidemic.
We're taking a closer look this week at Alzheimer's disease, and for one very good reason. More of us are getting it. In fact, in a poll commissioned by the Alzheimer's Association, 1 in 10 Americans said a family member has the disease. And it's not just the elderly. With advances in early detection, Alzheimer's is being diagnosed in more and more middle-aged people. Sharon Alfonsi concludes our series, Alzheimer's Fighting Back.
Snapshots of the most important moments in Patty Smith's life, but in her mind, they're starting to fade.
Where did you guys get married?
This was at the where we got married, the place? The Morrison House.
Patty has early onset Alzheimer's, a terrifying disease that steals the memories and personalities of people in their prime. Patty was just 51 years old when she was diagnosed.
Well, I worry about Jay and how this is going to affect him. I worry about my 2 children. The idea of them seeing me and me not knowing them is terrifying, absolutely terrifying.
Does she look like she has Alzheimer's disease? Why do you think you can see Alzheimer's disease with the naked eye? Why do you think you should be able to tell someone has Alzheimer's disease in a 60-second film clip? I had a mammogram 8 weeks ago. Was it positive or negative? You won't hazard a guess, will you? Come. Would you suggest that I wait until my breast tumor is visible to the human eye before I go to the doctor and ask questions? No. And what are my chances of treatment if I do? Virtually none. Yet we wait until patients with dementia can barely function before we take it seriously and think people ought to be assessed. The correct answer to does this woman have Alzheimer's disease is I don't know. I would have to see the test results. And the fact that we take for granted that we can see Alzheimer's disease by talking to someone for a few moments is one of the biggest problems that we have, because people wait and wait and wait. And if I did have a positive mammogram, do you think the doctor should say, well, you know, you're doing fine. You can cook dinner. You're not in pain. You can pick up the kids after school. Come back in 5 years. No, they don't. But even now, people start to show memory loss, and people will ignore it for years on end. And this is what we get. We now have aggressive assessment and treatment of stroke, aggressive assessment and treatment of prostate cancer, aggressive assessment and treatment of heart disease, and not aggressive assessment and treatment of Alzheimer's disease. And this is why it will become the #1 disease in this country. Because the myth is it's caused by aging. Aging is, in most people's mind, thought to be due to time, and you can't reverse time. Therefore, why bother? In fact, you occasionally still hear that it's not possible to diagnose Alzheimer's disease until an autopsy. If that's true, how do we have 5 million people in this country already diagnosed with it, and more coming? So these are some of the myths that we have to bust. We have to get rid of these myths, because as long as this information is swirling around, people are going to continue to deteriorate to the point that by the time they do go to the doctor, it's too late. Now I want to talk a little bit about Alzheimer's disease in detail. This is Auguste. She is the first person in the world to be diagnosed with Alzheimer's disease. This is a picture of Dr. Alzheimer's first patient. And these are the hallmark signs of Alzheimer's disease, and I know you've probably heard that it has to do with memory loss. You then lose your cognition. As the disease progresses, you have difficulty walking and standing, lose the ability to be continent, delirium, and hallucinations. But in fact, the number one, the leading edge of Alzheimer's disease is something that looks like depression. We call this depression prodrome of dementia. Let's take a look at the daughter of the woman in the first film clip and see what she has to say.
There were years when something horrible was happening that nobody knew what it was, and you were so little. Do you remember what it was like?
Mom just was vacant. You know, I remember sitting in a chair and just not being there. I mean, she was a mother of 10. She had 1,000 million things to do, and in her character it would be that she would stay busy all the time. She then started sitting a lot, sitting down a lot, and not doing anything, just staring off into space.
So they thought it was mental illness, not anything with Alzheimer's.
Depression, all of those. And so she ended up having 3 shock treatments, and then eventually went into a nursing home.
This is very tragic. She wasn't diagnosed correctly until after she got into a nursing home. This tendency to just sit there has 2 technical terms. In psychiatry, it's called apathy. In neurology, it's called abulia. In the elderly, a tendency to just sit there isn't really more likely to be due to depression. It's more likely to be due to dementia or Alzheimer's disease. This is the reverse of if you see someone in their early 20s or early 30s. Just sitting there is more likely to be due to true depression. So we have to let people understand that as time progresses, the risks for different diseases change. We know from research that apathy in late life signals risk of degenerative disease and impending dementia. And so when someone comes to the memory clinic, Tuesday mornings are memory clinic, a typical patient is an elderly female brought in by her daughter. I will look at the daughter and I will say, does your mother have memory loss? And she will say, yes, that's because she's depressed. And I'll look over at the patient, big smile. I'll ask all the questions for depression. No, 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 no. And I look at the daughter and I say, why do you think your mother's depressed? And the words I always hear are, she just sits there. In the elderly, that is a big red flag, but not for depression, for dementia. Let's take a look at the lady on Katie Curry.
Most young people are misdiagnosed, sometimes for years. When Patty's work as a banker started to slip, doctors chalked it up to depression.
And I would say that even in the elderly, it's misdiagnosed for years. We're missing years of treatment opportunity. Now, we actually know what causes Alzheimer's disease. In fact, it drives me crazy because on the news and on the media all the time, they talk about the mystery of Alzheimer's disease. Well, it was a mystery 25 years ago. It's no mystery now. We actually understand this disease at the molecular level, and we're learning more and more every day. We know the pathology of Alzheimer's disease. It's a slow buildup of a protein that we've labeled beta amyloid. This creates beta amyloid 42 deposits in the brain, and that is sometimes referred to as plaque. It's kind of a sticky material. This destroys the cholinergic neurons in the brain. This is going to reduce the production of the chemical from those neurons, which is called acetylcholine. It's going to stop the reuptake of glutamate at the NMDA receptors later in the disease. The loss of cells will start in the cortex. It often starts in the occipital lobe, which is the very back of the brain. Eventually, the whole brain will be affected. Now, this is what the plaques and tangles look like. This is a plaque here. That's a taut tangle. This is Dr. Alzheimer's personal drawing made looking under a microscope over 100 years ago. Over 100 years ago, there were no cameras. In fact, there were no media at all. If you wanted to teach your students, you had to be an artist. You had to draw the information yourself. And many of the early physicians were gifted artists as well as doctors. Now, we actually know how this works. Here we have the border of a cell in the brain. And this is the amyloid precursor protein molecule, and we all have millions of these. And some of us are going to inherit a gene. And that gene creates an enzyme. And that enzyme cuts this molecule just like this. And that piece called beta amyloid, that piece is sticky. I call them gummy bears in the brain. And across a really long period of time, as these gummy bears bump into each other, they stick, they aggregate. So let's take a look. We're here in the brain. That's a neuron. We're going to go past the neuron here. In the intracellular space, you're going to see little red pieces of beta amyloid. And across a very long period of time, these bump into each other and stick together. And this is a long period of time. 10, 20, 30, 40, 50, 60 years. This is a slow process, almost like rust. Here we have an amyloid plaque. This is now neurotoxic. It hits a neuron. It will kill the neuron. The neuron will try to save itself with a glutamate cascade. But one by one, neurons die. By the time someone has advanced to Alzheimer's disease, cell death is so prominent it can be easily seen on a scan. Unfortunately, that means that a great deal of cell death has already occurred. In fact, most researchers believe that Alzheimer's disease really starts the day you're born. That's when you get the gene. And that may be when the very first little amyloid plaque or little piece is released. But this is a really slow process. Again, it's like rust. When does your car start to rust? Starts to rust the day you buy it. In fact, it probably starts to rust the day it rolls off the assembly line. But it doesn't rust to the point that you can't drive it for an extremely long period of time. So we know this to be a very, very slow process. We know the cause, genes. We know some of the names of the genes. One of them is the APOE4 allele, and this is the one when you hear on television that there's a gene test, this is the test that is in existence. There's also a test for presenilin 1 and 2. This is a very small number of the people with Alzheimer's disease, but that's the gene for the very early onset. So if I had to guess, I would say that the woman on Katie Couric probably has the presenilin 1 or 2 gene. Unknown, 58% until a couple of months ago, and then we got another one. Now we have the SORL1, which we estimate to be about 30% of late onset Alzheimer's disease. And I assume that with time, we're just going to divide up the unknown section with more and more data across time. Now, this is about the time that someone asked me, well, should I go get the gene test for Alzheimer's disease? And here's why it's not really recommended. This gene is not fully penetrant. What that means is that you can have the gene and run positive on the test but not get the disease. There are some diseases that are fully penetrant. Huntington's, for example. Huntington's, you get that gene, you get that disease 100% of the time, guaranteed. Quite frankly, most genes aren't like that. Most genes turn on and off. Sometimes they turn on and stay on. But this gene is not 100% penetrant. So you can run positive for the test and still not get the disease. On the other hand, maybe you have one of these, something that we don't have a test for. Then you run negative on the test and still get Alzheimer's disease. So right now, the gene test will not give you very much in the way of reliable information. It might be interesting information, but it doesn't really tell you anything one way or the other. Now, we're always looking for biomarkers. We want to be able to find this disease as early as possible. And across time, we're going to be able to do that more and more. What you're actually looking at here is actual axonal transport of neurotransmitters in a neuron. This is an axon. This is the runtime. This is axonal transport in an Alzheimer's diseased neuron. And as you can see, we've got runtime here, but nothing much is moving. So this neuron is alive, but it's not working very well. When we look on scans like this, we can see the Alzheimer's disease here. But that bumper-to-bumper neuron, the one that's not working very well, is alive and will actually scan on most scans. But we want to find this disease as early as possible.
Well, we know that by the time people show symptoms of Alzheimer's disease, that they've already lost, some estimates say, as high as 50 to 75% of the nerve cells that are important for memory. And at this moment, we don't have a way of regrowing those nerve cells. So I think our best chance at slowing the progression of the disease and ultimately preventing the dementia is to find people before they're at that level of the disease.
So we don't want to be waiting until someone's scan looks like the one you saw here, because that's really late in the game. Now, I've indicated that, in fact, Alzheimer's isn't due to age, and in fact, memory loss is never normal. A healthy older person should have no more problem with their memory than they did at, say, age 60. And if you listen to NPR, you've probably heard Daniel Shore. Daniel Shore is in his mid-90s. Daniel Shore does not have much in the way of cognitive decline or memory loss. He's a wonderful commentator. How do we know that all cognitive loss is at some point due to disease and not to normal aging? One of the ways, because that's a big myth. The idea is, oh, well, she's just old. And then we write it off, and then by the time it's obvious that they have a disease, it's too late. One of the ways we know that is from this disease here. This is a disease called progeria. It's extremely rare, and these children die of old age by the time they're a teenager. This is a 14-year-old boy. They get all aspects of aging, wrinkles, cataracts, heart disease. They go bald. They don't get cognitive decline. Just like they don't get measles unless they're exposed to it, they don't get schistosomiasis, they don't get a million other different diseases. They only get the signs of aging. If cognitive decline was due to aging, every single one of these children would have it, and none of them do. But I was speaking once and somebody said, but Dr. Funk, some of these kids have the genes for Alzheimer's disease. It's almost 50% in the country. Yes, that's true. But they're not going to live the 20, 30, 40, 50, 60, 70, 80 years that it takes to show the symptoms. So time's a factor, but not aging. Aging does not cause decline.
One of the most remarkable things now that we understand it is how little nerve cell loss there is, how much the brain stays full of cells that we need in order to function normally. And that's something that we didn't used to know at all.
Now this is interesting because it forces us then to look elsewhere for the changes in the brain that are impacting function.
We look to diseases. It's not normal aging. So if you take nothing else away from this presentation, Alzheimer's disease is not caused by aging, and memory loss in the elderly isn't normal. Now, I very, very quickly want to talk about the specific incidence of specific dementias. Alzheimer's disease, pure Alzheimer's, is really only 10% of dementia. And vascular disease is only 10%. Most people actually have a mixture. This becomes challenging because we almost always have two diseases in place at the same time. And because when someone with Alzheimer's disease has a little stroke, they can have a rapid change, we actually have to realize that we're almost always looking at the pattern of two diseases interacting with each other. There's also Pick's disease and Lewy body disease, which I do not have time to go into today given the amount of time we have for this presentation. But treatment is available. That cholinesterase inhibitors are efficacious in the palliative treatment of Alzheimer's disease is now beyond question. Unfortunately, fewer than half of the patients who are diagnosed with Alzheimer's disease are ever even offered treatment for their disease. This is criminal. Delaying the onset of Alzheimer's disease by 5 years could decrease the number of demented individuals in this country by half, and I believe that we can do this now. So I want to end this section with just a little piece of research. Donepezil is the generic term for a medication called Aricept. It is one of the acetylcholinesterase inhibitors. They're all very beneficial. This is Donepezil. This maintains functional brain activity in patients with Alzheimer's disease. This is a 24-week double-blind placebo-controlled study. It doesn't get more obvious than this. No medication 24 weeks later, on medication 24 weeks later, and I can't give my patients any less care than I would give myself or my family. So I know which one I want to be. Right now, this is not a cure. We don't cure diabetes either. Not a single person in the history of the world has ever been cured of diabetes. But that doesn't stop us from using treatment. We have treatment for dementia. We need to use it. Now, I understand that at the moment we are slowing the disease down, but we can still look for small and significant changes. I understand this gal is demented. Look at her bingo card. But patients on treatment, and the longer you're on treatment, the better you, the more divergent from people who don't have treatment. People are easier to care for. They are more cooperative. Their neuropsychiatric symptoms decline. Right now, this is our definition of treatment success. So at this point, I'm going to stop this presentation. This is normally an hour and a half, and I have a 6-hour version where we go through a lot of the dementias and talk very specifically. Does anyone have any questions they would like to ask? And they're going to bring around the microphone for you to use. So you'll be on the tape. Yes.
I was curious about Down syndrome and Alzheimer's disease.
Down syndrome, one of the genes for Alzheimer's disease is on chromosome 21. The APOE allele is on chromosome 19. But if you get 3 copies of chromosome 21, which is what Down syndrome is, it's trisomy 21, it's almost 100% chance of getting a form of Alzheimer's disease. That's now that we have people living longer, even Down's patients are living longer, we then start to treat the Alzheimer's age 45, age 50. Any other questions? Yes.
I'm curious about prevention. Is there any, I understand the importance of early detection, but I read about people taking vitamin E, people taking ginkgo, people taking this, that, and the other. Is there any merit to any of these?
Depends on your definition of prevention. Let's use a different disease. Breast cancer is a gene. And in fact, we now have good tests for the genes. You're not going to be preventing the gene. We may someday discover how to turn the genes on and off, but that is not yet available right now. But when, and in fact, many of these things that are products that are for sale are a little bit oversold. You're not going to be changing the gene. But any woman who has breast cancer, the healthier she is, the better her body is going to fight the disease. So good diet, exercise, all of those things don't change her genetic structure, although in fact we're sort of learning that sometimes it can. But by and large, you're not going to be treating the gene yet, but you're making a healthier individual to fight the disease off. So the stronger your brain, the better your education, the more active you are. Healthy is healthy, and healthy can only be a good idea. I will say one thing about ginkgo biloba, however. It's important to know that that happens to be a blood thinner, and quite a number of people every year die from taking ginkgo, especially if they mix it with other medications that are blood thinners. The one thing you have to realize is that many of these over-the-counter additives interfere with other medications. If you're younger, that may not be such an issue. In older patients, if they're already taking medications, it may block it or enhance it. And so you have to be very, very careful with those types of treatments. One more question.
I'm curious, especially for our social work students, since detection is so important and since most doctors are not doing this yet, what can we as social workers do to make it more likely that we can promote what you're talking about?
Wonderful question. A neuropsychological assessment is currently the gold standard for detecting brain injury of any sort, but certainly dementia. They're sensitive enough that, and we use them often for the detection of learning disabilities in children. A really detailed neuropsychological evaluation will find strengths and weaknesses in everybody because no one has a perfect brain. In dementia, we can use shorter and more pointed assessment and find alterations to people's cognition fairly reliably. The general rule is anytime someone is struggling to care for themselves. My father is 86 years old. He does not have dementia. He has cancer. He doesn't have dementia. I don't go to his doctor visits. Why would I do that? He drives to MDN Cancer Center in Houston, goes to see his oncologist, finds his car, drives home, calls me up, tells me everything the doctor said because he's got cancer, not dementia. When people either, when I'm talking to doctors, I say when the family starts showing up in your office, that's a warning sign. And because I don't need to do that. If you think you now need to go to your parents' doctor's appointments because they're coming home, you say, what did the doctor say? Oh, nothing. Oops. It may be because they're not remembering the complexity of the material given to them. So whenever someone is struggling to do what they used to do well, that's a sign. For example, my father's good at mathematics. If he starts having trouble doing calculations, I'm not going to wait until he can't use a can opener. In fact, I'm probably not even capable of assessing his mathematical ability because he's pretty good at that because he's a retired NASA engineer. But, anything. You should not, you may slow down, but the quality of your abilities should not change across time, no matter how old you are, even at 105, really. All right, we're going to shift now to a different topic, the neurobiology of love. And this is sort of an introduction. I'm going to be giving this at a workshop at Harvard in either October, I think it might be November. And this is going to be the new Brain in Love, an update. We're going to talk about here the neurobiology of attraction and attachment. And once again, I always like to start with the most basic question of all. And in this case, it's what are emotions? The emotional system provides us with a method of communication. Social animals communicate. Animals who communicate with each other, live together, promote their survival, they're better off very frequently than animals who don't communicate. Reptiles, for example, don't communicate much. They have no social ability. And animals who communicate survive. For example, we have here lions and tigers. If you were to put 6 lions and 6 tigers in a cage, the tigers outweigh the lions by double. You have a 600-pound tiger, you have a 300-pound lion. Put 6 of each in a cage, come back in a few months, all the tigers will be dead, all the lions will be alive. Why? They're smaller. Because the lions will group together and they'll pick the tigers off one by one. Tigers are not social. They're not pack animals. And they sit there while the lions take the tigers down. So if you are social, if you can communicate, you increase your survivability at an enormous rate. So what has love got to do with it? Everything. The reason we no longer need claws and heavy fur and fangs is because we love each other. We have attachment and attraction that keeps us together. It's one of the reasons why we eat meals together. That keeps us all alive and kicking. So emotions evolved to assist social animals. Mammals have to select mates, reproduce, and care for their young. Reptiles, for example, do not do young care very much. They lay the eggs and go away. 3 important emotional systems have evolved to support these reproductive functions. Libido, which is basic sex drive, attraction, and attachment. Each of these comes from a level in the brain. We're going to talk about the brain's 3, we have 3 brains. And each is associated with its own brain regions and neurochemistry. Now, when you study neuroanatomy, it's really striking to realize that we have three brains. We have the old lizard brain, still intact. We have, that's the brainstem. We have the limbic system, which is the mammalian ability for emotions and social contracts. And it's interesting because when we talk about mental and emotional illness, it's the mid-level that we talk about. And then there's the human cortex. This is the newest part of the brain. If I were lecturing about learning disabilities, calculations, ability to learn foreign languages, that sort of thing, we would be talking about the cortex. So we have three brains. We have three levels of behavior. The brainstem is sort of the unconscious. It's hardwired. Your ability to breathe, hunger, thirst, the basics to keep you alive. The limbic system is more subconscious. It's sort of what we call instinct. And there reside the emotions, sadness, and the cortex is conscious and aware planned, and that's the easiest thing to change. For example, if you want to learn to play the piano, you can find someone to teach you that. If you want to learn to be in love with a particular person, that doesn't even make sense. We tend to fall in love. We don't tend to study in love. The words don't even make sense in the sentences. Now we're going to talk about the neurotransmitters. These are the basic neurotransmitters here. But the three basics for moods and emotions are dopamine, serotonin, and norepinephrine. We're also going to talk about hormones and peptides, neuropeptides. You're probably familiar, you've heard of estrogen, androgen, and testosterone. Excuse me, bring that back. There we go. But we're actually today going to talk about oxytocin and vasopressin, because these are very important molecules for attachment and love. Now, the neurobiology of love comes in three phases. There's lust, the ancient drive to reproduce. There is attraction, which has to do with mate selection, why him, why her. And attachment, which is more long-term, has to do with child rearing and protection of the family over a long period of time. Now, I'm not going to talk about lust very much, assuming you've done your own research here. I love this quote from Jared Diamond. Most of us do not realize how unusual human sexual practices are from the rest of the animal kingdom. Bizarre human sexual practices include having sex in private, having sex for fun, female breast expansion without lactation. Human females are the only female of a species that the breast does not go away after lactation is over. And there's a reason for that, which has nothing to do with feeding babies. Pair bonding without offspring. We have many, especially now in the modern age, we have many wedded pairs who do not have children. Male involvement in child rearing is relatively rare among species. And female menopause, which is not a sexual practice, but it's interesting to note that most of the women who've ever gone through menopause are alive today. It actually did not used to occur, primarily because women did not live that long. Libido. This is located in the brainstem. It's hardwired. This is hard. About the only way to get rid of libido is to have a disease as an infant. Mumps and a couple of other infectious diseases can occasionally take out the brain areas for libido. That's relatively rare, especially in this day and age where we don't have so much infectious disease anymore. This is primarily hormonal, estrogens and androgens. The goal of these hormones is sexual release, but this is not really what we define as love. And in fact, you can artificially inject people with testosterone, and this will increase their sex drive, but very few individuals define this as love when they do this in the laboratory. There are medications that affect libido. Medications that increase libido include Buspar, the amphetamines, methylphenidate, cocaine. medications that interfere with libido, SSRIs and antipsychotics, medications that interfere with sexual arousal, SSRIs, anticholinergics are things like Valium and Ativan, and alcohol, and medications that interfere with orgasmic response, including SSRIs and beta blockers. Note that something shows up here 3 times. Yep. Now, can anybody identify this substance? Ritalin. We take all the impulsive kids, male kids in this country, and we jack up their libidos by giving them Ritalin. It's true. Now let's talk briefly about attraction. This is instinctual. This is now we're up in the limbic system. The neurotransmitters here are dopamine, norepinephrine, and serotonin. Attraction requires high levels of dopamine and norepinephrine, really turns on the reward system. Low levels of serotonin, and this creates what we call courtship behavior. Goal here is appropriate mate selection. Notice that we get high levels of dopamine. Notice that we need low levels of serotonin. There is considerable discussion in the medical literature now about what happens when people take artificial medications which increase their level of serotonin. What would that be? Prozac, the SSRIs, which are known to interfere with all 3 of the levels of attraction and mate selection and attachment. This is a quote from Dr. Helen Fisher. She's suggesting that SSRIs have a major impact on the 3 distinct areas of the brain systems that are sex drive, romantic love, and attachment. And she thinks that people need to be aware that taking these medications may interfere with their skills in relationships. I'll let you hear it from her.
The worry is about antidepressants. Over 100 million prescriptions of antidepressants are written every year in the United States. And these drugs are going generic. They are seeping around the world. I know one girl who's been on these antidepressants, serotonin enhancing, SSRI, serotonin enhancing antidepressants, since she was 13. She's 23. She's been on them ever since she was 13. I got nothing against people who take them short term when they're going through something perfectly horrible and they want to commit suicide or kill somebody else. I would recommend it. But more and more people in the United States are taking them long term. And indeed, what these drugs do is raise levels of serotonin. And by raising levels of serotonin, you suppress the dopamine circuit. Everybody knows that. Dopamine is associated with romantic love. Not only do they suppress the dopamine circuit, but they kill the sex drive. And when you kill the sex drive, you kill orgasm. And when you kill orgasm, you kill that flood of drugs associated with attachment. The things are connected in the brain, and when you tamper with one brain system, you're going to tamper with another. I just simply say that a world without love is a deadly place.
Now, animal attraction is extremely important, and size does matter. Helen Fisher's point is that when we change the chemicals for these signature things in the brain, we sometimes may not understand fully the effects that we're going to get. It's important to realize that there is no such thing as mental. Every thought you think, every emotion you ever feel is a complex combination of electricity and chemicals in the brain. And when we change these chemicals through medications, we may be changing aspects of ourselves that we are not really fully aware of. Now I want to talk a little bit about sexual ornamentation. This initially confused Darwin, and there's actually a quote in one of his papers that he was so upset by the peacock because he couldn't figure out why the peacocks had tails, because this made them easier to catch and eat by predators. And he actually said, he was so upset, he said looking at peacocks would make him throw up. He was so upset with this, because the tail seems to have no purpose. but it does have a purpose. It allows the females to see who is the strongest of the males. And this is a quote from Darwin: "Refined beauty may serve as a charm for the female." In human beings, sexual ornamentation may be a little bit different. And this next quote, I'll just let this one stand on its own.
Drive a nice Porsche so I can get chicks, so I can have sex.
There you have it, male ornamentation. Now, before we had gadgetry, when we look back in non-technical societies, human beings actually fluff themselves up a little bit more like birds and other animals with bright colors. These are men. These are 3 Wadabi tribes men dressed up for one of their mate-choosing rituals, which is a group dance where they jump very high and attract women with their beautiful, beautiful costumes which they make. And one of the points that Darwin made is that all human emotion is universal. And so sometimes we can still see aspects of this in modern times.
Happiness is in the mind of our next semi-finalist as the Miss America Talent presentation continues with Susan Ellen Anton, Miss California.
Forget your troubles, come on, get happy. You better change.
As you can see, they look very similar. All right, that's enough of that. Interestingly, Darwin's statement that all emotions were universal was as unhappily accepted as the other aspects of evolution. In England, no one wanted to hear that people in other countries and other societies and cultures had the same emotions as Englishmen, because that kind of ruined the fun of going to their country, grabbing their stuff, and hauling it back to London. And if you want to see some of the great works of art from around the world, you have to go to London because they were fond of bonking people over the head and stealing their stuff. Darwin said, no, these are human beings too. They all have the same, we all share the same emotional system. We now know that's because we all share a limbic system. And the limbic system predates the development of the human, and is almost identical in all races of people. So let's talk about the neurobiology of attraction. This is the work of Dr. Helen Fisher, and I highly recommend her book to you, Why We Love, came out in 2004. I'm going to hit this very fast just because of the time issues. Novelty, focused attention, increased energy, dependency, exclusivity, and sadly, impermanence. The first 4 or 5 are generally what we describe as romantic love, looking something like this.
They say when you meet the love of your life, time stops. And that's true. Your mother was never supposed to marry me. She was engaged to somebody else.
Forget it, kid. Don't waste your time. She's out of your league. You don't even know me. Sure I do. You were hot stuff back in Hickville. But here in the real world, you got squat.
Now, I may not have much, but I have more determination than any man you're ever likely to meet.
Sandra Templeton, I love you and I will marry you.
That was drying out.
That's from the movie Big Fish, which I also recommend. The thing that Hollywood movies tend to not emphasize is impermanence. The romantic phase of relationships tends to last between 4 to 7 years. The romantic chemistry that Helen Fisher is describing tends to fade. And we now have reason to believe from research, this is approximately the amount of time it takes to raise a child to relative independence within a tribal group. So a 7 to 10-year-old child is generally able to function in non-technical societies. And so that is, if you remember the penguin movie, and the penguins raise the chicks, of course they get a different partner every year because they can raise a chick to independence in a single year. So the length of pair bond tends to match the ancient amount of time it takes to raise offspring to survivorship. And in human beings, this appears to be about 7 to 10 years. Now, all of this is relatively interesting and fun, but there's a real reason to study the neurobiology of love. And that is our understanding of the role that love and attachment plays in our tendency to become addicted to certain substances.
When Cupid's arrow hits the heart, it starts a flood of brain chemicals that may keep us coming back for more. Anthropologist Helen Fisher says the rapture of romantic love clutches the brain much like an addiction.
I think that love is a drug. It's one of the most powerful drugs on earth. It's turned the world. Wars have been fought for it. Wars have been ended for it. Our novels, our plays, our poems.
Fisher and her colleagues reported to the Society for Neuroscience that they found the brain's love button by scanning the minds of 17 people who identified themselves as being madly in love. The MRI brain scans revealed that gazing at a picture of a sweetheart aroused mental regions associated with attention, motivation, and reward.
When somebody falls madly in love, the primary thing that happens is that the brain's reward system goes into high gear.
A brain region called the VTA secretes the chemical dopamine, which triggers this feel-good mechanism deep within the brain. Awash with dopamine, the mind then focuses attention on the object of affection. In fact, Fisher found that test subjects said they think about their beloveds as much as 95% of the day.
You can't stop thinking about the person that you're in love with. It's obsessive.
So if you find yourself hooked on that feeling, you might as well face it. You could be addicted to love. I'm Warren Schoenfeld.
And in fact, one of her concerns is that when you take a medication that treats obsessions, that treats OCD, like Prozac, that you may in fact be preventing people from falling in love, and that they may choose the wrong person, the wrong, or whatever, but you've altered the system in ways that we don't understand. This is that system. This is what in the clip they called the brain's love button. It's not really a button, it's a circuit. The VTA is here. And this circuit exists basically to cause us to become addicted to each other in order to reproduce, bond, have children, and take care of them. Otherwise, the species would not continue. Now, the problem is that there are artificial substances that can fit into this system, and some of them are listed here. Nicotine goes in here, alcohol here, the opiates, nicotine and alcohol, opiates, alcohol, PCP, marijuana. So what's essentially happening here is we have a system, but because we're human beings and we now control our environment, we have opposable thumbs, we can create things, we have created substances which actually hijack this system. As an example, I'll show you a lovely picture of an albatross couple here, a male and a female. And these birds live on the Galapagos Islands. They would be in jeopardy by a simple artificial object. If I took a bunch of tennis balls and took them to the Galapagos Islands and sprinkled them around, in a few years there would be no birds like this left. Why do you think that might be? These birds will knock their own eggs out of the nest and roll the tennis balls in. They'll sit on the tennis balls. The eggs will die. Why do they do that? Well, they don't actually know that there are chicks inside the eggs. They just have a brain circuit, much like we do, that is rewarding for sitting on white, round objects. And tennis balls are whiter and rounder than the eggs, about the same size. And this is the same thing that happens to us. Substances happen to get into our brain that are stronger than hit our circuit for human attachment and mimic the feeling of being in love. So when the birds are sitting on the tennis balls, they think they're fine. Their brains are all happy, full of dopamine and norepinephrine because they're sitting on what they think is a nice, rounder, whiter object. Everything is wonderful. And this is actually why, when people become addicted to substances, that they give up their families, that they give up, that they ruin their lives, because the lower part of the brain, the brain stem, and to some extent the limbic system, is getting the reward that should only come from love and attachment and raising children. So this is the explanation. This is understandable. We understand why this occurs. Now I want to end this section with some interesting new data. This is from one of Helen Fisher's articles. She is continuing to do this type of work. This is a functional magnetic resonance image, an fMRI. And what you're seeing here is the areas of the brain that light up when people are in love. And the interesting thing about fMRI is it takes pictures of thought. And Helen Fisher can actually look at these scans. In fact, I could teach you to do it in 15 minutes. To tell the difference, you can look at the scan and tell whether a woman is looking at a picture of her husband or her son. It's that specific. So this type of technique is revolutionizing neurobiology, not just love, not just addiction, but we can look at an enormous amount of human functioning by using this powerful technique of functional magnetic image resonance. So I'd like to just sort of sum up here. The emotions evolved to assist social animals to communicate their needs. Mammals have to select mates, reproduce, and care for their young. 3 systems have developed to do this: libido, attraction, and attachment. Each is associated with different areas of brain neurotransmitters and neuropeptides, and in the longer version we go into that in great detail. Now, research suggests that much of our need for relationships is biologically based. That doesn't mean we don't have an ability to alter our behavior. I mean, I can change my biology. I can go work out in the gym for 6 weeks and I will build muscle. You can change your thoughts, you can change your thinking patterns through psychotherapy, through education, through religious training. There are lots and lots of ways to change the brain. And when you do, it shows up on the scans. fMRI scans easily show the benefits of psychotherapy. Psychotherapy changes the brain in ways we can see on scans. I think knowledge of the early origins of relationships can illuminate some of the problems that modern couples may have when confronting issues regarding libido, attraction, and attachment, and the longer presentation goes into that in detail. So, questions regarding love and attachment?
Hi. Can you clarify the couple of slides that you showed that the brain was hardwired? A couple of things that it was mentioned that the libido is hardwired, and I want you to clarify a little bit because there are a lot of evidences showing that there's evidence for the neuroplasticity, that brain is constantly changing and adapting depending on the environment or the stimulus that you're exposed to. So there are lots of discoveries we are making a lot of discoveries of the brain and that their brain's new function, or not the new function, the adaptational function. But you did say a couple of things that you identified, some of the areas of the brain is hardwired. So I just want you to clarify those issues.
Mm-hmm. Remember, we talked about 3 brains. The brain stem doesn't change very much and is not very plastic. We have found areas in the human cortex, the upper level human part of the brain, that is quite plastic. And it's interesting to note, in fact, when you go through neuroanatomy, when they give us brains to actually dissect, the brain stem is actually very tough physically. When you have to dissect it, you actually have to take a bread knife and really, it's tough. It's hard to get through. It's very fibrous. The midbrain, the limbic system, much less so. And the human cortex is actually the consistency of runny eggs. In fact, you can't dissect it until it's been soaked in formalin, which is a kind of plastic. Otherwise, it would just fall apart on you. So the cortex is literally plastic in the sense that it actually fluctuates. And we now know that there are areas of the brain which do grow new neurons, primarily in the hippocampus. But the hippocampus is not part of the brainstem, and the hippocampus is not part of the libido system. It does have to do with attraction and attachment, however. Those areas of the brain are more changeable. The term plasticity, however, is used in sort of different ways. Sometimes people will sort of use it to mean changing in thinking or behavior patterns. In neuroscience, it's actually used to talk about the creation of new neurons. That doesn't happen very many places in the brain, but one of the places it does is the hippocampus. Okay. Yes?
Do different psychotherapies show up differently on the fMRIs?
Oh, that's an excellent question. I actually don't know the specific answer to that, although if you start Googling around, you'll find some stuff, I'm sure. The one they use most often in the studies is cognitive behavior therapy. And I think they've taken a look at psychoanalysis, and I know that they're not real pleased with what they're finding there. But that's actually an excellent question. And what I'm going to do is go home and Google around to see what I can find. Very often when you get to a journal, they'll let you sign in and see the abstracts, so you can kind of for free, and then you have to kind of pay to get the whole thing. But you can usually figure things out from the abstracts, although sometimes they won't let you have the pretty pictures unless you pay for the article. And a couple of the bigger journals have become magnanimous, and anything more than 2 years old, everybody gets for free. So, good question. You can tell me. Yes?
Thanks. I'm not sure my question is very interesting or as much as her question. I'm thinking more of elections.
More of?
Elections.
Elections?
Yeah. I would like to know if there's, you would say that people may get emotionally attached to candidates. I'm thinking of Obama, and people would vote for candidates just because they feel like they love them rather than they rationally like them.
Oh, I'm sure it's an aspect, yes.
Do you know if there's any research going on in that?
I don't know of any research. But again, the way I learn stuff is through Google. Everything's available everywhere now, which is just so wonderful. But certainly, a lot of research is done by marketing people who don't necessarily publish in medical journals. But clearly, I mean, our attachment to anything uses this circuit a little bit. I love to knit. In fact, I'm wearing one of my vests here. I'm attached to knitting. I'm sure that knitting helps me have more serotonin and dopamine in my brain. So it doesn't have, I mean, the system is there so that we will feel rewards for doing things that are good for us, like eating, drinking, reproducing. But as human beings, we have a really broad range of behavior now and things that we find pleasurable to do. And it's the same system. We don't have special systems for sailing or watching movies. It's all the same reward system. But there's enough individualization that some people like to knit, some people love old movies, some people love to race cars. So there are ways that system can be turned on in individual people. And I imagine it has something to do with how we're attracted to certain candidates. Okay, I'm going to shift. Well, all right, one more. Sure.
My question is about the addiction, and
Yes.
We all know that the some substances are promoting the good relationships. Like alcohol is a good example when you use it in right place and right quantity. And I was wondering.
I don't know that at all.
You don't know that at all.
No, love existed long before alcohol.
Right, but what I'm saying is that the alcohol sometimes promote love relationship.
I'm not going to be able to buy the premise there.
Okay.
I know of no, I mean, it certainly makes people less inhibited, but I don't think it actually promotes love. That, in fact, it probably interferes from the research that's done in substance use. It would suggest that really it's an interference. It's not, it doesn't augment. What it will do is take an inhibited person who is shy and make them a little bit looser in a social setting. But the substance itself is not promoting love, not in the sense that a dopamine enhancer is. Those are interferences, actually. They block the system. They don't, by turning it on inappropriately.
Just one more question.
Okay.
Hi, you were just talking about the reward system being similar in attachment. I'm curious about when we talk about love addiction, whether from a neuroscience perspective, if chemically you make any distinctions between love, romance, fantasy, intrigue.
Not that I know of in research. The addictions research is now unifying in the sense that we now know that it doesn't really matter what you're addicted to, it changes the brain in the same way. So they're much less interested in whether it's food, cocaine, gambling, etc. The trigger may be different, but the brain systems and the changes in the brain are almost identical in everybody. And so they're less interested. The trigger will probably be interesting to someone who's doing specific therapy, but it's not of interest to the researchers. Or not so much, anyhow. We know they're not. We know that, for example, gambling addiction is just not that much different from alcoholism. You just, once you get in the brain, you're not going to be able to tell the difference when looking at the brains of those two types of people. But the treatments might be a little bit different. All right, we're going to switch over now to understanding depression. And we've got some new information. We're going to talk a little bit, and we're going to go beyond serotonin and talk about some of the new information we have. Interestingly, depression goes way back in time. Unlike Alzheimer's disease, which we've known for 105 years now, autism for 60, 70. Depression descriptions go back pretty much as far as we have recorded history. So we certainly know that this has been around a very, very long time. And for a long time, I was often requested to give presentations on depression, and I always turned them down until quite recently because, oddly enough, we still don't understand it. Not hardly at all. Although we have treatments for depression, to do the science of major depression was extremely difficult. It was like, well, what am I going to talk about for a day-long workshop? There's no science. And so, but things have changed in the last few years, and so the full depression presentation, which I think I'm doing next Saturday, goes through various theories, knocks them down, and then ends up with now what we think may really be something that we can really take to the bank. So for a long time, we had various symptoms and disorders and descriptions. All of them have been lacking. The serotonin hypothesis, we now know, has serious problems in it. And what I do is start out talking, I want to contrast these three disorders, autism, depression, and Alzheimer's disease. because of the different level of scientific information we have about each of these three. Autism was first described by Dr. Ausberger in 1938, further studied by Kanner in 1943. Symptoms were not standardized until 1981, so as you can see, this is a really quite a newly described disorder, no known treatment. And we're all aware that the apparent incidence of autism is going up. Some of this is probably because the term is now being used quite loosely. I was reading in the news recently of a child who was described as being autistic, and later in the article it indicated she had mitochondrial disease. Well, this is a child who had mitochondrial disease. It gives symptoms of social difficulty, mental retardation, etc. So this is becoming a slang term now. So how much of this is correct diagnosis or not is difficult to say, but certainly we do know the incidence is increasing. Alzheimer's disease, described over 100 years ago, scientific causes are well known and understood. This is one of the best understood of modern diseases. Modest treatments, no cure. Depression, described by the ancient Greeks, so this goes way back. Symptoms are understood. We all know, what depression looks like. Scientific knowledge here is really limited. However, we have relatively good treatments. So here's kind of a graph here. Alzheimer's disease, well understood, limited treatments. Autism, advancing rapidly, no treatment. Depression, poorly understood, relatively good treatments in comparison. But I've noticed that the general population tends to look down here. Everybody thinks we understand depression. We don't. People think we don't understand autism hardly at all, and we do. And everybody thinks we don't know anything about Alzheimer's disease when it's one of the best researched and understood diseases in the history of medicine. So I like talking about this because there's a whole lot for me to cover. I don't particularly treat autism, but I could certainly give a presentation because there's plenty to look up and present. Problem with depression is what to say. It's just busted theory after busted theory. So you don't have to take this from me. Let's hear it from Dr. Eric Kandel, who is absolutely one of the greatest neuroscientists in the history.
All the three diseases we are talking about here, autism, depression, and Alzheimer's is the best understood. And one of the paradoxical situations in all of medicine, but certainly in psychiatry, is that there isn't a direct relationship between being able to treat a disease and understanding it profoundly.
So that's how we get this type of graph here. Now, you'll notice here that I said that we actually have a fair amount of scientific knowledge about autism. Would you like to know what causes autism? We'll let Dr. Kandel tell you.
The increased apparent incidence of autism is thought in part be due to the fact that people married later in life, in the last decade or two, and that old sperm, in fact, is maybe a predisposing factor to autism. In fact, one of the interesting things about the genetics of autism is that you often have two parents that are normal, a sibling that is normal, but a child that is defective. And it is thought to be what is called a germline mutation, either in the sperm or the ovum. So this is not a mutation in the basic genome of the person, but only in the genome of the sperm or the egg. It's a spontaneous, what is called de novo mutation. And there is a whole range of phenomena called copy number variations that indicates that not just a single gene, but a whole segment of a chromosome. For example, in autism, chromosome 16 is the short arm of it is not infrequently involves several different cases.
So what Eric's saying here is that it's not that you're born with this genetic damage. It's what happens is that during the generation of the sperm, during your lifetime, there's damage occurs to the genes in the testes in this case.
That's right.
So that you generate altered sperm, and sometimes this isn't just a sort of classical mutation in a single gene, but sort of whole segments of genes that alter in the amount, the numbers that are there.
Lost or displaced or duplicated.
And here's some of the research that they are referring to. Advancing Paternal Age and Autism. And you're probably aware that the more people there are in a study, the stronger the study results. Note here that there are over 300,000 people in this study. So this is a strong piece of scientific research. So let's talk a little bit about modern theories of depression. Oh, I did want to mention that, note that when Dr. Kandel was talking about autism as a genetic disorder, he also indicated that neither parent had it. Genes are a little different than people think sometimes, and it's possible to get a genetic disorder that your parents don't have. Genes change a lot. The genes you're born with aren't the genes you die with, and genes modify across time. So when we talk about whether something's genetic, anytime you hear that word used to mean unchangeable, that's not right. Genes change. Let's talk a little bit about depression, public perception of cause. Emotional weakness, 71% of people think that that must be a factor. This is not going to add up to 100%, by the way. Bad parenting, patient's fault, incurable, result of sin. Only 10% of Americans think that depression is a brain disorder. We have been defining depression in different ways for a long time. These are my books off of my shelf. I started training in the DSM-2 way back when. The definition is still in flux. Who knows what they're going to come up with the DSM-5. It's always been more than low mood. That's really important to understand. All definitions include vegetative signs, cognitive and behavioral features. And DSM-2, this is pretty much all there is. Excuse me, let's go back here. There we go. Before insurance companies and before research and before medications, this was just a very, very limited definition. This is from the DSM-4, and this is not a bad set of definitions. I find most people who are out there diagnosing depression have never read it. It has two things. I actually work in a hospital. My practice is hospital-based, and one of the things that I'm often noticing is the number of people who come into a hospital get upset with being severely ill and get put on an antidepressant medication. However, the DSM-4 actually specifically excludes reaction to medical conditions as a definition of major depression. Not only does it say that here, it mentions it twice. That major depression is not to be diagnosed as a reaction to having a significant physical illness. That's an adjustment disorder. Now, you can be very, very unhappy and have an adjustment disorder. Nobody is saying that these people are functioning well at all. But it's amazing how the word depression has just shrunk, or has expanded to be all of human behavior that's negative. Adjustment disorder is defined as a clinically depressed affect. It's associated with a true life stressor. Can be present, can be around for a long time. In most research, it doesn't respond much over a placebo. Most people with adjustment disorder adjust, and they'll do so whether they're on real medication or a sugar pill. Psychotherapy is excellent treatment. Life problems, life skills. This is actually a fairly well understood phenomena. This is a little clip from someone you probably recognize.
You are depressed, and we need to deal with that. And not by giving you some pill. You don't have an endogenous depression. You don't have something that's biochemical. This is reactive to your situation. If we could empty your internal dialogue out on a piece of paper, we'd all be depressed. It really, if we read that, because wouldn't you agree? You say very negative things to yourself all the time. I don't ask myself why you're depressed. I ask myself why I'm not. If I was saying to me what you're saying to you, I too would be depressed. So you've got a job to do, and I'm going to help you do that. I'm going to get you some help to do that. I want to help you to do that, but you've got to change that internal dialogue.
So here's Dr. Phil, essentially with a very nice distinction between a chemically based disorder and a guy who needs some good psychotherapy. And this is a distinction we all need to be more aware of, so that we don't just go around sprinkling medications on people for whom they're not going to be particularly beneficial. Grief. Grief is a word that's disappeared. Very often, since I'm a geriatrician, I find people who have been placed on treatment with SSRIs for grief. There is no research that shows that this is effective. Why would there be? Why would taking a pill make you happy that your husband has died? This is kind of defies logic. If someone has abnormal grief, if they have a history of major depression and they are triggered into a major depressive episode due to grief, that's a different situation. Research shows that the medications work well there. But really, it's not uncommon when I'm looking at someone's medications. I see your mom's taking Zoloft. When did that start? And he says, well, after my dad died. And when did he die? 7 years ago. You know, if we put your arm in a cast, we'd probably check it more than once every 7 years. So sometimes these things just get perseverated. I think that we need to remember that sadness is a normal emotion. It's necessary for mammalian survival. A lot of animal brains, including humans, negative emotions are how we survive. Stress, anxiety, sadness, these are all important survival mechanisms. Separation distress is a signal to preserve important social relationships. And in the wild, animals who don't show distress on separation aren't going to live very long.
One of the most important things for any mammal to have is care. No young mammal can survive without maternal devotion. So young animals have very powerful emotional systems to solicit care when they're lost or out of contact with their parents. They cry. They show separation calls. And this alerts mothers usually, sometimes fathers also, to come back to look for the offspring. Well, when they're showing these cries, we assume the animal's feeling terrible. And we assume that when the animals get together again, chemicals are activated in the brain that feel good.
Now you can imagine that a bear born without the ability to feel sadness, anxiety, and upsettedness will not make the sound. The mother bear will not come back to find it, and those genes will disappear. And in fact, reptiles do not give out separation calls. There is no pair bonding in reptiles. And in fact, when reptiles make sounds, in fact, they almost never make sounds under anxiety because it just brings predators. The sound has to outweigh increased predation. In mammals, it does. But we have a very powerful system for upsettedness. And that is part of what we see in depression, anxiety, and it doesn't just disappear because we're human. It is part of what we need to understand about the brain in order to understand emotional illness in human beings. What depression isn't, it's not a short-term reaction to an environmental stressor. It's not a substitute term for sadness. It's not normal grief. Depression is not a major cause of apathy and reduced activity in the elderly. That would be Alzheimer's disease and dementia. Let's talk a little bit about our ability to define mood disorders. This has never been easy. Sadness is an emotion that is universally experienced over the world. Distinguishing normal sadness from a mood disorder has and continues to be a real challenge. A lot of medical conditions, it's like, well, when is it an illness? It's not just depression or the emotional disorders. Everybody will feel a little heart flutter every now and then. When do you take it to the doctor? When do you take to the doctor? When does he decide you need a bypass? When does he decide you need an angioplasty? All of these are not easy things to define. But we need to understand that mood disorders are syndromes. When someone just says, well, I'm depressed, that doesn't mean 2 seconds later that they should have a prescription for an antidepressant medication. But this actually happens. We have to assess for the syndrome, and sadness is only one aspect of this syndrome. We need to realize, in fact, the best definition of major depressive disorder is this one from Dr. Helen Mayberg.
Well, let's make it very clear. A clinical depression is not having a bad day.
Right.
It's having the worst day that doesn't end. And there's absolutely nothing you can do about it. And you punish yourself as it's happening, and you have no clarity as to what's causing it, why it's happening, and there's absolutely no escape.
If someone can actually identify the cause of their depression, they don't really have major depression. They may have an adjustment disorder, and that can be quite severe. But if you can point to and say, that's making me depressed, then what you don't have is the disease of major depression. And treatments need to take that into account. So mood disorders are syndromes. We look for abnormality of mood. That in and of itself is not major depression. All of these things need to be assessed, but often are not. I have a friend who some years ago, she was going through a bad patch. She was at her primary care doctor's office, and he said, how are you doing? And she said, well, I'm a little down. And he said, well, let's get you on something. And 10 seconds later, she had a prescription for Prozac. That is word for word the assessment. That was it. And because of this, you're probably aware that in the water system in America, every time you drink a glass of water, you get a little bit of Prozac and a little bit of Viagra. I don't know. I think, who knows? Risk factors for major depression include gender, and this is sort of out of textbooks. Textbooks will tell you that gender is twice as common in women as in men. I don't believe it. When we look at teenagers, the figures are different, and male teens are more depressed than female teens. Myself and a lot of people think that there is some gender bias in the adult definitions because they don't look at aggression. Aggression is conduct disorder, and so I think a whole lot of depressed males end up in conduct disorder rather than major depression, and I'm not sure that's accurate. Age. Peak onset for major depression is between the age of 20 and 40. Depression is a disease of young people. By and large, although never say never, but in general, people do not just start to have major depression at 75. When you get severe mood disorders in the elderly, you need to look for another cause. Dementia, reaction to disease, grief, change of household, moving into assisted living, things like that. Family history, 2 to 3 times higher risk in families with a history of depression. Marital status, unmarried men and married women at higher risk. That's actually well established. Postpartum, of course. Negative life events, only modest correlation. Negative life events don't cause major depression. And early parental death, only modest correlation. So let's take a look at our more modern theory of depression. In 1965, Dr. Joseph Schildkraut suggested that depression was associated with low levels of the neurotransmitter norepinephrine, and early treatments for depression focused on this neurotransmitter. Elavil and the tricyclic antidepressants are selective norepinephrine reuptake inhibitors. And this just happens to be the molecule. This is actually what norepinephrine looks like under a microscope, and because it's pretty, I just stuck it in here. So the tricyclics were actually developed from antihistamines in the 1950s. They inhibit the reuptake of serotonin and norepinephrine. Imipramine was derived from thorazine. Elavil is the one we're most familiar with. Elavil has another use. It also treats neurogenic pain, pain that comes from upper motor neuron disease. As effective as SSRIs, whenever they do tricyclics versus SSRIs, SSRIs are not more effective. They just have a different side effect profile. They are highly anticholinergic. That's very important for someone like me who works with people with Alzheimer's disease, because Alzheimer's disease is a disease of acetylcholine, and we don't want to be taking any more out than we have to. And the tricyclics are what sometimes researchers call dirty drugs. They hit lots of neurotransmitter systems, not just norepinephrine. Now, when we start talking about neurotransmitters, we're essentially talking about monoamines. This is just a word for a particular type of chemical in the brain. And the serotonin hypothesis is a monoamine hypothesis of depression. So what's a monoamine? It's an organic compound. It has a nitrogen atom. All of this is relatively uninteresting. But we're going to want to look at the recipe that makes serotonin. So here we have tryptophan, and the brain knows how to put all of these pieces together to form serotonin down here. And serotonin is just defined as a monoamine. There are polyamines. This is a string of monoamines. These are 3 polyamines, and serotonin is one of them in this string. These polyamines, these 3, are part of perception of pain. And when we treat people with tricyclic antidepressants, we sometimes alter the pain perception system. And people that have major depression, they sometimes have enhanced or reduced ability to perceive pain. So the monoamines are developed here in the body of the neuron. And this is just the list of the monoamines. Notice that melatonin is on the list here. Histamine, as in antihistamine. But there's serotonin. And the monoamine hypothesis is simply that antidepressants appear to boost serotonin, norepinephrine, and dopamine. These are monoamines, therefore depression is caused by a deficit in monoamines. That's just the basic logic. There's a problem here. A simple relationship between low serotonin equaling low mood has never been established. Depleting serotonin in the lab and in human beings does not directly cause depression. So you drop people's serotonin, they don't get depressed. Directly increasing serotonin does not treat depression. So something else is happening here. So this just sort of, serotonin on empty here, this just isn't quite what it is, it's not this easy. So after many years and many studies, a direct link has never been proven. Interestingly, most studies of antidepressant medications fail to show an effect greater than placebo. And in fact, 2 professors at UConn pulled a lot of data from pharmaceutical companies which sort of hid the data for some of the research, and it is their opinion that the SSRIs would not meet current criteria for going on the market. Research, however, has moved on, and now we're looking at the receptors and various gene expressions as a link to mood regulation. So this just isn't quite what it is. It's more complicated. I actually, of course, don't quite have time to go into this level of complexity. This is a cell with the chemicals in, but we are now looking to see that monoamines play a role, but they are not the whole story. This is actually the best description of depression I've ever found. Unfortunately, it's written in researchese. It's not in English. But depression may be a pseudo-monoamine. In other words, it looks like a monoamine deficiency due to impairments in signal transduction from the monoamine neurotransmitter to the postsynaptic neuron. I'm going to translate this in just a second. To a postsynaptic neuron in the presence of normal levels of neurotransmitter. What they're saying is the problem is in the signal transduction, not necessarily the receptor or the thing that's sending the signal. So we now know that this is not just serotonin anymore.
Neuroscientists have long known that antidepressants help relieve the shortage of a brain chemical called serotonin. But now researchers have shown that antidepressants do more than that. They stimulate the growth of new brain cells, which turns out to be necessary for recovery from depression.
Often it takes a month or more for the drug to reach full therapeutic efficacy. And that cannot be easily explained by just an increase in serotonin.
Rene Hen and his co-workers at Columbia University focused on the part of the brain that controls moods, called the hippocampus. They studied a type of mice that is depressed from birth. If such mice stay on antidepressants for a few weeks, they normally get better and would go for the food pellet in this test setup. But these mice hesitate to eat even though they're hungry. They've been exposed to radiation and can no longer grow new cells in the hippocampus. Therefore, the antidepressants haven't worked for them.
And that's what we found, basically, which is that even though the mice look normal after having been irradiated, they now no longer respond to antidepressants.
Hen's findings may lead to new drugs to treat the blues.
There are two hopes, basically. One is that we're going to have drugs that work faster, and the other one is that we're going to have drugs that work with less side effects.
Next, Hen will give his mice compounds that directly stimulate the growth of new brain cells. If these cure depression in the animals, they may be tested in people. I'm Karen Lurie.
So essentially, they stopped the efficacy of antidepressant medication by stopping the area of the brain that makes the new neurons as part of neuroplasticity. So here's where we are now, the neurotrophic hypothesis of depression. Neurotrophic is a word that means growth of neurons. So this has something to do with the growth and death of neurons. There is a substance in the brain that is sort of miracle grow for new neurons. It's called BDNF, and this stands for brain-derived neurotrophic factor. 90% of neurons are present at birth. Over our lifetime, some will die, but we do create other neurons. We do create neurons during life. We have to have BDNF to do this. It's active in the hippocampus and the frontal cortex, and it's defined as a neurotrophin. It's essentially brain food. BDNF is brain food. And when you put it on neurons, they grow, and if they don't get enough of it, then they commit suicide and die. So when we go back to our cell here, notice that we were looking at the monoamines, but look what's right next door. BDNF. We now know that what SSRIs are doing is turning on BDNF. The monoamines also regulate gene expression in the nucleus. That single sentence deserves an hour of presentation to talk about how genes change. They change rapidly, and BDNF has a lot to do with the alteration of genetic expression in the cells. But increased genetic expression in the hippocampus is associated with the remission of depression symptoms. And here is where we get a direct result. When we look at the role of BDNF and gene expression, we get a direct and very predictable set of responses. So here's that slide again, that really complicated slide. And over here we have serotonin, but look what's right next door, BDNF. This goes down for gene regulation in the cell. Gene regulation happens all the time. And the genes in your cells in your brain are changing right now. So we now have the gene hypothesis. Stress can damage the gene for brain-derived neurotrophic factor. Some people are also probably born with damage to that as well. We know that by affecting the genes for BDNF, we promote the death of neurons. Major depression appears to be a slow neurodegenerative disorder similar to Alzheimer's disease, but one we're better at treating. Now I'm going to just show you briefly, very briefly, some of the articles where this information is found. If you're interested, just Google BDNF and depression and you will get tons and tons of research, many of it very new. Sometimes I end up adding something that comes out the week of the presentation that I'm giving. This is, however, relatively new information. It's been the last 10 years that this has really been developed. Brain-derived neurotrophic factor produces antidepressant effects in behavioral models of depression. Requirement of hippocampal neurogenesis for the behavioral effects of antidepressants. This article would strongly suggest that Alzheimer's disease, which causes the death of hippocampus, means that SSRIs will be less effective in that population, although that study has not yet been done. Sustained hippocampal chromatin regulation in a mouse model of depression and antidepressant action. When you really, really seriously stress these mice, you downregulate the BDNF gene transcripts. Imipramine reverses it. So antidepressant induces increases in BDNF. It opposes and overcomes cell death, creates new neurons, and treats depression. So when you turn that gene off, you take away the wonderful fertilizer for the nerves, and you bring BDF back in, nerves grow. We now know that SSRIs, the tricyclics, electroshock therapy, and cognitive behavior therapy all affect BDNF. And BDNF is a player in these diseases, and this is going to open a huge, huge door to new research and new treatment. Any questions? Yes. Actually, he'll come up with the...
Earlier there was something about tryptophan,
Yes.
and I've always heard that tryptophan, if it's the same chemical, whatever, is an ingredient in turkey.
Yes, it is.
And
It's
I know I'm
it's pretty-
always feeling good after having turkey.
It's pretty small trace amounts, and probably people are feeling pretty good because they are very full and have eaten a lot of fat, which the human body adores. But there's enough tryptophan to be measured. It's just not, most of that sort of thing is overblown a little bit. But there's chocolate has a psychoactive ingredient in it as well. Yeah. Yep. Any other questions?
Can you show the last slide again, what helps BDNF?
Sure.
Oh, okay. I was just trying to figure out what's helpful to improve the growth of neurons. I wasn't
Well, that's an active area of research right now. However, that's not the sort of thing you want to run out and start changing. Most things don't cross the blood-brain barrier. There's a reason we have these nice stiff skulls. What's happening up in our brains is delicate. It's easily disrupted. The only sugar crosses the blood-brain barrier. Nothing else that you eat, only sugar. Now, having a healthy body attached to your brain is a very good idea, but you can't. Someone once actually asked me what food they could eat to make their amygdala better, and it just doesn't work that way.
And exercise? Is there any studies?
Exercise is great. We need to eat right, stay fit, and exercise. There'll never be a single disorder that's not a good idea for. You know, there is going to be no disease where late diagnosis, bad diet, and no exercise are just a really good idea. That's just not going to be happening. Another question?
Does the neurotrophic hypothesis have any implications for anxiety?
That's an excellent question, and one, to my knowledge, no. This is specifically low mood, but certainly those two systems interact. So it's a little bit like Helen Fisher. Once you mess with something, you're probably messing with other things as well. It's hard to start changing things in the brain that you don't domino into other systems. When you're feeling down and low and depressed, you're certainly not able to cope as well, and you may become more frightened. Also, to the extent that depression hits the love system and has to do with attachment, attachment has to do with anxiety and separation as well. So you're going to domino into that system at some point. But exactly how BDNF interacts with anxiety, I don't know, but I'll go home and Google anxiety and BDNF, and then I'll find out. Thank you guys for coming. I really appreciate your attention.